Any questions in the first row?
I know she's got calcium deposits, and they're severe now to the point like where, should she shave them? Should she get them off, even though we've met other people who've had those come back again? And also the medications, the contradictions of the medications are causing this, or is it which one in particular that you know that does cause this, if you've had any experience or seen it?
Okay, let me repeat the question. What to do about these calcinosis, calcium deposits? So is it any medication causing it? That's one question. Or is it the disease causing it? So I'll answer that. It's the disease causing it. It's generally not seen as a side effect of any particular medication. The second part of the answer is what to do with it. Should we do the surgery? Should we not? If you do the surgery is the last step we recommend. You do the surgery because everything else has failed and it is causing serious problem. And the reason for that is because surgery is not definitive. It's going to help you for the time being because you take the large deposits off, but it may come back. So we don't recommend surgery as a first step, and we don't recommend it until that's what you have to do. Otherwise, you can't live a normal life kind of thing, right? Then you do the surgery, and you do get relief because they can debulk a lot of it, but there are complications from it because it may not heal because there's so much of calcium deposition, so the skin may not heal post-surgery, right? And it may come back. So that's not a first step, but just the last resort.
Yeah, I mean, calcinosis, like I think I was talking a little bit about yesterday, does remain kind of the most challenging aspect of the skin disease to treat. So and Dr. Charles, I think, briefly mentioned this when she was speaking, but controlling the active disease, I think we do try to make that our first priority because we do think that if the disease remains uncontrolled for a long period of time, you might be more likely to get calcinosis. But still, some people, after the disease is fully controlled, they'll go on for years still developing calcinosis. So we clearly don't really understand what's driving the process. We sometimes think about treating the inflammation associated with calcinosis, like depending upon the site it's at, like if it's on an area that's getting constant pressure, if it's red or swollen. We'll use medications that have more of an anti-inflammatory basis. And there is sort of a long list, and one I don't know you can say is definitely superior to another. I work at Stanford, and we often try if it's very painful, antibiotics like minocycline, which sometimes can help relieve if it's really swollen, and then similarly intravenous immune globulin or IVIG sometimes helps if they're very inflamed, but certainly doesn't help everyone. It's a huge area that we need to have better therapy for, and it's nice that sodium thiosulfate may help for some people, but it's definitely not effective for very deep, large lesions, for which I do think for better for worse, surgery remains our most effective therapy. And we have a surgeon who's very good at it and treats all of our patients, so we have actually fairly good outcomes, but it's definitely not for everyone.
The other treatment I would say is bisphosphonates has been seen to control it or prevent the progression. Again, none of the treatment is definitive and none of the treatment is for everybody. So these are all treatment options. I won't say that we know step 1, step 2, or step 3. These are all good, all options. And on the surgery, I want to comment, the center, for example, Stanford has a dedicated surgeon who knows how to take care of it, who has experience, so they can get good outcomes. At our center, our outcomes are satisfactory, but I can't say that's my first recommendation to the patients because I've seen some complication of lack of healing, for example, or the calcinosis coming back. So again, a lot of these experiences depends on center to center as well, and who you're dealing with. What's the expertise of that particular person or a surgeon? So, all right. So let's go to this test, okay? All right, go ahead.
I'm being treated, but so I guess I've never taken any medication before I was diagnosed with DM. And my thing was to keep trying to get off of it as quick as possible. But after hearing what Christine said, I should be on higher medications and feel great. Is that, and not be on lower medications and feel okay?
Okay, so I'm going to answer it a little bit separately. So the idea is that Okay, I'll repeat the question. Okay, sure. I'll repeat the question. So, okay, so the question is, should she stay on the medication on a higher dose longer than trying to get off the medication once you're feeling better? That's the question, right? Okay. So my short answer is, longer you're on the medication, lesser are the chances for the disease to relapse. Okay, but you have to balance that with the risk or the side effects of the medication taking long term. So it's a fine balance between the benefit and the risk of the medication. So for example, I recommend patients to first control the disease with higher doses of medication. But once the disease is in remission on medication, slowly try to decrease the medication. Don't rush your doctor to get off the medication because you're feeling great. Okay, slowly let them decrease your medication, and to get to a lower level, generally we get to a level of, let's say one immune suppressive drug, let's say it's azathioprine at a lower dose, and maybe 5 milligrams of prednisone, and then we continue that for 6 months or a year, and then we say, okay, on a very low dose medicine the patient is still doing great, now maybe a time to get them off. So it's a slow and steady process, and I tell the patient when I first diagnose them, if everything goes well, expect to about a year or 2 years of treatment at least.
Which I'm at 2 years, and I was on prednisone now for a year.
You're off of prednisone for a year.
But now I'm on methotrexate.
How much dose?
0.7 injection.
So that's a moderate dose. So I think if you're doing great, then it can be reduced.
Down a little bit, and I had a little bit. I felt bad.
So then I would not recommend that for you. For another year or two, don't try to go down. But then again, your immune system constantly changing, right? So just the fact that you had a relapse, small relapse, while you were cutting down your methotrexate, that means for a year, sit tight, The immune system has by that time evolved and changed in your body. Then you can try again.
So don't rush it.
Don't rush it, yes. Okay. Any comments?
Thank you.
I don't know how many have issues, oral issues. What I have had forever and ever, my parotid glands get swollen, my tongue gets swollen. Is there anything that I can take to just kind of calm that down?
That's a good question. So the question is, what do we do with the oral issue? She's been having problems with her parotid gland swelling, probably oral dryness, mouth dryness, maybe even dry eyes. So that is not common, okay? That happens in certain patients who have an overlap with Sjogren's syndrome. And I bet if based on your symptom, I can tell you clinically at least, you have an overlap with Sjogren's syndrome. And Sjogren's syndrome is a very common syndrome for myositis to overlap with. And so it's very common to see that kind of feature. But just pure myositis, it doesn't happen. For that particular problem, you really need treatment for Sjogren's syndrome. For example, there are drugs that can stimulate your saliva. That can be helpful, okay? Like pilocarpine or Salogen. Have you tried those drugs? So there are drugs that your doctors can give you to stimulate the saliva. There are biotin products that can help with the dry mouth. For parotid gland swelling, sometimes a little slight massage can help. A little bit of low dose of prednisone tapers can help. So there are things there are drugs, but they have to focus on try treating Sjogren's rather than just treating myositis, okay?
I don't know if he's going to ask this, but I will. He's been on IVIG since 2008.
Okay.
Okay. His doctor tried to taper him. He's been taking it every 6 weeks.
Mm-hmm.
He tried to taper him off in May, and he tried to taper him to every 8 weeks.
Mm-hmm.
Well, he had a huge flare.
Mm-hmm.
A huge flare. Okay. So that means he should just stick with what he's at for ever. Because it didn't work, and it's been
answer
this
that
long.
question? No, you have experience with IVIG.
Yeah, I mean, I think I'm glad your doctor tapered in that way. Usually going, sorry if people didn't hear it, the patient was on IVIG and then tapered from 6 weeks to every 8 weeks and had a huge flare. And should you stay on IVIG indefinitely? Yeah, IVIG, we like a lot for dermatomyositis. Can be one of the best medications for skin disease, and the safety profile is very good. And so, yeah, typically speaking, we do taper the frequency more often than tapering the dose, although you can do either one. And yeah, I would say in your case, yeah, to continue this 6 weeks for a much longer period of time. Yeah, like another maybe 6, 12 months. And maybe maybe trying to go to 7 weeks or something is maybe in a year or something would be the next step. But
what is this reason for wanting to taper him off? I mean, when it doesn't last the 6 weeks because he starts breaking out.
Oh, I see. Yeah, certainly if you're not fully controlled on doing every 6 weeks, yeah, it definitely wouldn't make sense to taper.
That's why his numbers are good, and that's why his doctor tries to do it, but he's not.
Yeah, clinically, I guess it would be more important to follow his clinical symptoms, and he may, even need it more than every 6 weeks, every 5 weeks to prevent you from having that period where you're really not doing well. And yeah, you may have to be on it for a much longer time, but people are, and we consider it safe. Some people are on it for life for immunodeficiencies. I don't know if you have any.
Yeah, no, I agree. In your case, based on what you're telling me, why, unless until you are having a problem in going and doing the infusions, I won't get off. Especially your body's telling you that in 5th week towards 6th week, your body needs it. So why, your body's telling you, the recommendation of tapering is when you have a controlled disease. You're saying you're controlled, but towards the end of it, you get to know that your body is needing it. Just listen to your body. Okay, I'm going to go to the next row. Any questions from the next?
Will you take him home with you?
All right, let's let's move to the row. Here. Okay.
I several times here, and for myself in particular, I had a skin disease for a while, not definitely diagnosed, and then an acute onslaught of the muscle
weakness.
I ended up in the hospital for really serious and I've heard a couple times those with that acute onslaught. Is there any that they have better luck with it not coming back, not as many flare-ups and I've run into some people that have it, have the muscle part just over a
period of time. Yeah, so the question is, what's the difference in somebody having an acute, all of a sudden develop muscle weakness, severe muscle problem, as compared to people who develop slowly over the period of time? And to be honest, I don't know if there's any differences in terms of their improvement per se. Both groups seems to improve on treatment. The people who have acute muscle weakness, they are actually going to be at a little bit of a problem because they've lost their muscle too quickly. So the body hasn't been able to compensate for it. So they may be really weak for long period of time until the medicine kicks in. Whereas the patients who having slow decline in muscle, their body's compensated, and then we treat them, they slowly improve. So there's a lag period from the treatment we start to the time you see improvement. And that's going to be more in your case when you have acute loss of muscle, where there's a huge loss of muscle. So now the muscle needs to recover. It takes time for the muscle to recover. First, the inflammation needs to go down. Then the muscle needs to build up. And as you know, if you've done exercise, it takes a while for the muscle to recover. So the more acute the loss, more time it's going to take. But I think eventually both should. We see that in patients with anti-SRP antibody or HMG coenzyme antibody. Those are the patients present with acute muscle loss. And those are patients who goes from playing basketball to being wheelchair bound in like 2 to 4 weeks. When we treat those patients, it will take about a year for them to get to their level, or even more sometimes, because they've lost too much of muscle too quickly. And that's the only thing I can tell you on that.
Yeah, I was just, you're asking a great question, which is sort of about the natural history of the disease. And it hasn't really been well described, to my knowledge, in adults. In the juveniles, they've done a better job at sort of assessing if the disease is sort of monophasic, just sort of happens sort of one big flare, polyphasic, lots of flares, or if it's sort of a chronic process. It hasn't really been done well in adults yet, so I don't think I have a great answer to your question.
Is anyone talking about using oxygen to increase the exercise potential, since it is a vascular disease, and when I describe what it feels like, I'm treated at Stanford with IVIG, it feels like that when you're a kid, you put a rubber band on your finger, and it goes numb, and then it starts to burn, and then the blood goes surging to it, and I get that surge into my thighs and into my diaphragm and into my shoulders. When I use oxygen and exercise in a hot pool with juice and inhalers, I make progress faster. I can get my cardiac fitness back in about 12 to 16 weeks. It takes forever. So what I want people to hear is don't give up on your exercise. If you've been sedentary, it can take a long, long time. I used to be able to get ready for a 5K in 2 weeks, and it would take me now 24 to 50 to get there. But I decompress at altitude and in airplanes. But normally during the day, I don't need oxygen. But to use it when I exercise, long drives, like windy drives, I would fall asleep in the car because I was using more oxygen than I could mount. I could swim with my arms or my legs, but if I put them together, I sink. I can't get enough, fast enough to the muscles to use them. And I really think it's an area that could have a potential grand benefit.
I mean, to be honest, it's a tough question for me. Her question is, should we use oxygen while doing exercise to supplement the recovery? And I don't have a good answer for that. I have not heard that before. I have not heard that idea before. And maybe Helene is a better person to answer that question. What I've heard is that oxygen to the tissue, muscle tissue, does go up on exercise program. That has been proven. So if you continue to do exercise program, the oxygen that is reaching to your muscle tissue go up over the period of time. And can we fasten that by giving external oxygen? I don't know. And doesn't sound like a much, to me, I mean, to you may sound like right, but to me it doesn't sound scientifically good. Just that's all I would say, because I don't have much experience with it.
Right. I have no lung involvement, but my experience was that after the colonoscopy, after an ER visit, I would have 2 or 3 good days. And the commonality was that they would hook me up to pure oxygen out of the wall. When I went and got my IVIG, they would put oxygen on, and I could walk much further. And I learned when I was on the treadmill, if I was singing, I could go further because I was compressing, I was adding pressure into that lung capacity and increasing the diffusion of oxygen.
We do know that breathing exercises helps, okay? Your experience is very unique. I've not heard that before, but it's possible that oxygen may have a role to play. As I was saying, people feel better when the oxygen level eventually increases in the muscle tissue after doing exercise. So there may be a role, but to give it as a treatment, I've not. No,
I know no one's heard of it, but it takes care of pain for me, so I take nothing for
That's
pain.
a good.
If I'm foggy in the brain, it perks me right up, and then I don't need a nap. My fatigue goes down.
Yes. Okay. All right. Maybe the next row.
Well, mine's kind of a continuation, because when Pauline the other day, she talked about the lactic acid buildup in pain patients, which I've never heard before, because I do have problems with my legs. She talked about capillaries being swollen, and that's part of the problem with not getting the oxygen. So is this a conversation that's part of the DM conversation you would have with your doctor? Because I've never heard it, and I've had this since 2005.
So, first of all, that's all true. That lactic acid builds up, oxygenation to the muscle tissue goes down, and all of that can be reversed to a certain extent with good exercise program. So, if you continue to do good exercise program, eventually your muscle tissues will be better vascularized, so that lactic acid buildup won't be there because the blood is taking care of it. Oxygenation to the tissue will be better. Fatigue will be less. So all of that at biochemical level is happening. But clinical level, I can tell you, if you increase your exercise capacity by slowly exercising and building your muscle up, you're going to be much better overall.
Is there like for legs, because we all seem to have the leg issue, is there something like the perfect exercise to help us? I know we're looking for the perfect one.
I am not aware of any particular exercise. There are exercise programs that can range of motion stretching, and then you start with range of motion and stretching and then start resistance exercises, because resistance exercise is what your body needs to build up the muscle. But I tell them for a first week or 2 start with range of motion and stretching, because they need to get accustomed to it to reach the resistance level. All right, any?
I have a comment. This really isn't a question, but I think it's Stacy
Yeah, you were saying about your doctor slowing down on the medication. Well, I was diagnosed in 1991, and I had my doctor, my rheumatologist, for 26 years, and then she's the one that diagnosed me right away, so that's why I feel like I'm doing so well, and I've responded well to medication. Well, then she is now semi-retired, so I don't see her anymore. So the rheumatologist that took her place, he wanted me to go off the spell step. He says, just stop it, just stop it. And I can't believe my rash just came with a vengeance. And now I'm back on 2,000 milligrams again, and I'm having a hard time getting rid of it. It's been like 6 months now. So I just really heed their advice. When they say go slowly, listen to what they say. You want quality of life?
Oh, yeah. I guess my question was, is there more damage with the medication?
No, I mean, there's potential. We always worry about longer the medication stays in your system, longer it's going to maybe do something harmful. But if you're tolerating the medicine well, in terms of tolerance, and also your doctor's also looking at your blood. If both of those things are good, then I don't think you should rush. Shouldn't you try later on? Yes, you should try in future, but you shouldn't rush.
My question is, well, for myself, that my muscles are fairly well medically controlled, but my skin not so much. And so I'm wondering if a flare in my skin would trigger a flare in the muscles.
Yeah, that is a good question. Yeah, she's asking, her saying her muscles have been well controlled, but her skin's been flaring, and wondering if her flaring skin could lead to a muscle flare. Yeah, I mean, in general, it's hard. In general, the diseases or the organs can have different disease courses. Like the muscle can sort of be inflamed independently of the skin, and the lungs too. So they don't always all run together. So it's certainly possible that because your skin's flaring, the muscle could start to flare too. But at least maybe me being a dermatologist, generally we see patients whose skin kind of ends up being active long after their muscles have been sort of stabilized. So yeah, it's common for people to have ongoing active skin disease even when their other organs are stable.
So it's not like going in the sun and getting a skin flare would immediately trigger a muscle?
Yeah, not usually. I mean, I suppose it is possible to have that happen, but usually no. It's more your skin will get worse if you're really sun sensitive and you get a skin flare. I don't know if you have any.
Yeah. So skin flare-ups not necessarily would mean muscle flare-up. It can happen though, but not necessarily. So I have had patients where the skin is very well controlled, but they have little mild active disease, okay? But they're fine. They say, I'm living my good life. I don't want to do anything more. And for them, I tell them, okay, that's fine. Because just little activity in the skin and little flare-ups there, which you are happy with and can deal with, doesn't mean that it's going to lead to muscle flare-up. So, but the severe active disease are more chances to go into muscle and other organs. If you are severely active in your skin, you should treat that. Okay? But borderline disease activity, mild disease, which is fairly well controlled, get into trouble sometimes when you go out in sun, I don't think you need to worry about that much on that.
Okay.
I was wondering about. Oh, sorry. Okay. I'm going to try to make this as short as I can. I have 4 autoimmune diseases. I started out with ankylosing spondylitis, type 38, a genetic marker. 30% of those people get psoriatic arthritis. In 2009, I had a big flare-up of all kinds of rashes, and my dermatologist was a good one, head of dermatology at Tulane, diagnosed me with psoriatic arthritis. And then later, lupus. But in the meantime, I took Humira, which was a wonderful drug for me as far as the control of the psoriasis. But I didn't have any muscle issues then, okay? No muscle issues, just skin issues. So when I began having muscle issues and I was on Humira, my rash was masked by the Humira. And I was taking care of my mother, and then all of a sudden it started going downhill with the muscles. So I got off the Humira and went downhill even more and ended up with the diagnosis of the DM. Okay. They immediately put me on the steroids, and if I'm on IVIG, because I had taken methotrexate to something else, I couldn't take it, so I went directly to IVIG. I've had 10 treatments of IVIG, and I know it's working. And I'm down to 5 milligrams of the Pridobin. My doctor's now talking about getting me off of this, and I'm still not totally, and I'm 69 years old, I'm an old lady. I want to stay on my IVIG for the rest of my life because to me, I have heart disease. I've had a heart attack in the past.
What's your question?
My question is, should I advocate to stay on this for the rest of my life? That's my question. If IVIG is working, you know, I've had problems. And
Let them in.
Yeah, I think everyone heard the question. But yeah, I definitely, you know, one of the sort of principles we work with is to taper the most sort of toxic medicine first. So oftentimes that's prednisone. But yeah, you know, there's probably not any significant risk for you being on IVIG for as long as you need to. You know, that's expensive and you have to get an IV placed, and you can, you know, there's some other side effects like headaches, but no, I wouldn't say you have to get off it, although there may come a time several years down the line when you're doing great and you could definitely give it a try, you know, because IVIG, because it gets out of your blood, you know, in around a month or so, you can sort of quickly tell if you need more, if you space it a little bit. So, and usually you can prevent the flares pretty quickly if you get it again. So no, I think you can at some point maybe consider tapering it.
Next question.
Question regarding the sun. I was just diagnosed last November. I'm doing really well in the therapy. I am an outdoors person, have been terrified to go outside because my rash was so bad. What is the, suntan lotion and everything, what is the amount of sun that you can do? And I don't know if that's a question you can answer or if it's just individual to the person or...
Yeah, it's a good question about like how much sun is okay in dermatomyositis. Yeah, it's hard to know. I will say, not to be sacrilegious as a dermatologist, but that like only about 60% or so of dermatomyositis patients are really truly sun sensitive in the sense that the sun will like activate their disease and make it worse. So there's sort of a large component of dermatomyositis patients where they can get sort of routine sun exposure and not flare their disease. So it's helpful to know the person's history. Like if you know that you get things if you know the sun has played like a huge role in your disease, it makes sense to like practice good sun protection. But I don't know. I can't tell you like, you know, is 5 minutes, 15 minutes going to be fine. I would be, if you're on therapy, I'd be surprised if getting like 5 or 10 minutes of sun is going to really make things worse. It's usually like get an hour of sun and you burn. Certainly that's probably going to make it worse. But I don't want people, just as like a dermatologist, I guess, to be paranoid about the sun all the time if they don't have to be, because it can really impact your quality of life. So I think like using an SPF 50 sunscreen, wearing a hat, or, you know, those things are reasonable, which I'd recommend to most people.
Next row.
I have a primary immune deficiency, CVID, and dermatomyositis and interstitial lung disease. And the immunologists say, we've never seen this with, you know, the primary immune disorder. Have you ever run across patients with dermatomyositis who also have primary immune disorder?
Yeah, so first of all, primary immune deficiency syndrome or primary immune deficiencies have been known to be associated with autoimmune diseases, like even rheumatoid arthritis for that matter. So I'm not surprised. Is it rare? Yeah, we have 2 rare diseases to come in together is rare. But I'm not surprised. Next one. Any questions? Yeah.
My question relates to non-biologic and biologic treatments. I have dermatomyositis with interstitial lung disease, the anti-synthetase Jo-1 antibody, and for 8 years I've been treated with prednisone and Imuran. The ILD has increased over the past year and a half. My liver function test has been going up this past year. the doctors, the pulmonologists, rheumatologists are debating whether I go on rituximab or CellCept. They couldn't agree on it, and it seemed like they were going for the rituximab, but one of the rheumatologists feels, in her experience, that patients with interstitial lung disease do better with CellCept, even though that might not be the first one. So they're thinking I should try the CellCept next, stop the Imuran, and just monitor it. If the CellCept isn't working, then could go to the biologic of the rituximab. And I'm not positive. How do I know if it is or is not working? Is it my lung functions and the skin improve or get worse? Is that how I know it's working?
So the question is what to do in worsening interstitial lung disease. Should we use CellCept or rituximab? That's the main question. And how do we figure out what's working and not? Well, first of all, interstitial lung disease, both CellCept and rituximab are good drug. So your doctors can debate about it, but I don't think that anybody can win the debate because there's evidence for both the drugs and both the drugs are good. In general, we recommend going step up, and step up is CellCept first. And so in your case, for example, I would give you CellCept. I'll monitor your lung function studies every 3 months or every 6 months, and then a CT scan in 6 months or a year. If on CellCept your lung function studies are stable, your CT scan is stable, and your oxygen requirement or your breathing, shortness of breath feeling on certain distances about the same, I wouldn't go for rituximab. I would continue on CellCept. But let's say in a year, there's evidence to suggest on lung function studies, CT scan, and your symptoms that things are slowly progressing or getting worse, then I will move on to rituximab. If that's answers your question.
They monitor your blood work every month on CellCept. Is that what we monitor?
So generally what we monitor is liver function tests and blood counts. We monitor initially every month because we are increasing the dose, but once the dose is stabilized, we monitor it every 2 months or 3 months.
Thank you. My name is Angie, and I have PM and ILD since last year April, and I'm currently on CellCept 5 days a day and telephone 9 and 10 milligram 1 year a day. So my first question is there any studies that especially applies to Asian group that I should especially pay attention to? For theories that I heard from this conference, is that universal that applies to everyone?
That's a good, maybe you have more experience with Asian population.
Yeah, that's a good question about, as people who are Asian and have dermatomyositis, those are things that are specific to them. Yeah, I think like we've been talking about this conference, what's probably more important, at least for the disease, probably more important for the disease features are the antibody, the autoantibody that you may have in the blood. That may do a better job at defining kind of what your major risk factors are for interstitial lung disease or cancer. But yeah, in the Asian population, there is a high Asian population in Silicon Valley where I work, and of those patients who have a certain antibody called MDA5, they tend to have worse lung disease, and we tend to see more patients with that antibody there. So whether or not there's something genetic that's sort of more common in people who are of Asian descent to make that happen, it's not really clear. But other than that, it's hard to say just because you're Asian, you should do this X, Y. It's probably more based on the antibody, and then race can have a sort of secondary implication.
So generally, it's pretty universal, the theories and treatments that I heard from this conference that apply to everyone.
Absolutely.
And my second question is that I know it will be a high-risk pregnancy if I do want to get pregnant in future, but how does that affect the baby's health and also my safety?
That's a very good question. I'll talk about it because recently we're writing a review on pregnancy and myositis. So there are a couple of things. In general, if your disease is controlled and your medications are not toxic, the pregnancies are successful. Okay, so in general, it's a good situation. It's a more difficult situation when somebody is lupus or rheumatoid arthritis. But in general, for myositis, disease is controlled, medications are non-toxic, you shouldn't have any problem. If the disease is not controlled, you should first control the disease. That's definitely because active disease may affect your pregnancy and the fetus to certain different extent. Even then, mildly active disease has not shown to have any major problems during pregnancy. Okay, but the toxic medication needs to be off. So if you're on Cellcept, you can't get pregnant on Cellcept. Okay, so your doctor would have to transition you to safer medication like Imuran is safe during pregnancy and can be taken long term. So those transitions needs to be made before you plan to get pregnant.
So even though I'm on prednisone and Cellcept, I would change Cellcept to another.
You would have to do that if you're planning to get pregnant, because you can't get pregnant on Cellcept. Prednisone is okay. Low dose prednisone is okay. 10 milligrams or low is okay for pregnancy.
So for a baby's health, you won't like that much.
You would have to follow with a high-risk OBGYN and your rheumatologist or dermatologist very closely, but there is certain risk, definitely. But if your disease is well controlled and a lower level of medication, less than 10 milligrams of prednisone on Imuran, you should. The chances are that it's going to be successful.
So I don't have to wait till 100% off the medication.
If you can, yes, but not necessarily. Yeah.
And sorry, I have a last question. So in future, if I do have the flare-up period, my symptom is going to be worse than the first time I was diagnosed, or is it going to be like less severe?
I didn't get your question. Was
if I do have a flare-up?
If you have a flare-up, worse than it's very unpredictable. I don't know if you have any experience with prediction. Generally, the flares on treatment are milder, because you're on some level of treatment, but once you're off treatment, the flares decide what they want to do. Okay. Next question, then maybe this row, or no, next row. You don't have to ask questions, so yeah. We can keep moving on.
I'm fairly newly diagnosed DM, and I've been hearing a lot of positive things about IVIG. I just don't know anything about it. And how do the doctors decide when to try that as a treatment? What are we looking at?
Yeah, well, IVIG, is an effective therapy, particularly for this skin disease, but also not in everyone. It's probably around 80% of people get either partially better or significantly better. But mostly it's a very individual decision, just based on your other medical problems and if you've failed any other therapies. You typically speaking, like for skin disease, if you have sort of fairly moderate to severe skin disease, we usually try methotrexate or Cellcept as probably something before you try IVIG, partially because of the cost, and you have to get this monthly IV treatment. But then if those are sort of failing, then IVIG does become sort of one of the next line treatments. And mostly it probably depends a lot on which doctor you're seeing, if they're comfortable using it, if they have an infusion center that they work with, or if they work with home infusion companies to get it done at home. So this is sort of an individual decision.
Hi, thank you for being here. I have DM and interstitial lung disease and Raynaud's phenomenon. As for son, I get like I have the flu. I'm severely, even by indoor UV light if I'm there, so I feel very ill from the sun, so I do stay out of that. I initially was lungs. I was on a pulmonary unit for 6 days, is how all of this kind of transpired back in 16. Was kind of in bed for about a year now, much better than that. So now I'm starting to get increased joint pain. I'm on Cellcept, 2,000 milligrams at this point. They had talked about quinacrine in addition to, I tried Plaquenil, and I got ill on that, was unable to take that. So with the quinacrine, it sometimes can help with joint pain, I believe, and then maybe tamper down the effect of the sun. And when they say it can sometimes help with joint pain, does that mean if I don't take it that there's more damage being done, or is it just kind of a comfort?
Yeah, I'll take the joint question. So if you're having joint pains but no signs of inflammation on the joint by the examination, the likelihood is the joint's not going to continue to get damage. It's generally when we see active inflammation, swelling, tenderness in the joint, or redness and warmth. That's what you have right now. So in that case, yes, if you continue to have significant active disease on the joints, slowly the joints will get damaged. Okay, so you should try to treat it. Whether it's with quinacrine or some other treatment is up to your doctor. But yes, Plaquenil and quinacrine does help with the joint inflammation and pain, so that is a reasonable option. Whether that has effect on the skin in terms of the sun interaction, I'm going to have our dermatology colleague to answer that.
Thanks. No, it definitely can. I mean, Plaquenil, yeah, the antimalarials, hydroxychloroquine and quinacrine, yeah, they definitely can reduce your sort of sun sensitivity. So it's worth trying. It may not make it, probably wouldn't make it go away, but it may reduce it to some degree. So it's a worthwhile try.
Thank you.
All right, next.
Hi, I'm curious about antibodies. You mentioned earlier that there are some good antibody panels and some not. So I'd like to know your recommendations on that. Also, I had a blood draw that was sent to the Mayo Clinic for the Mayo antibody panel.
Yeah.
After I started taking prednisone, so I didn't get any antibodies. It came back negative. Was it a bad test? I need to have it retested?
So generally, Mayo Lab is decent. I would say their testing is pretty good, and I would say I would believe that. Just because you're saying that you are on prednisone, that doesn't make the antibody go away. And so the fact that you were on prednisone when you got the antibody probably decreased the antibody levels a little bit, but it doesn't make it go away. So if it was negative, it probably is negative. 20 to 30% patients don't have antibody, or maybe we don't have discovered those antibodies yet. So it's quite possible that I wouldn't worry about it if it was negative, especially if it's done from Mayo Clinic.
So is that good news?
I won't say it's a good or a bad news right now. I think it's a neutral news, okay? Why? Because there are antibodies that are bad antibodies. So if you happen to have one of the bad antibodies would have been good news. If there are antibodies which are good antibodies, so if you had good antibodies, not having an antibody is a bad news. So it's so it's tough to say. You're kind of in the middle if you don't have an antibody. Okay.
Questions for Matthew. The sunscreen issue, we sometimes go to third world countries and we're exposed to sun. What do you recommend on the type of sunscreen and any particular brands that you think stand out over others? There's such a flood in the market in this area.
Yeah, it's a good question about, what brand of sunscreen or what to recommend for sun protection. Yeah, well, so people who are sun sensitive from dermatomyositis, we recommend a broad spectrum sunscreen. Fortunately, almost all sunscreens now are broad spectrum, meaning they cover both UVA and UVB radiation. And then an SPF 50, like 50 would be, you'd want to at least select something that high. And then also importantly to reapply it if you're going to be out for more than 2 hours. Those principles are probably the most important. The brand, I would say, is whatever you're going to put on the most, because it honestly, I don't think there's huge differences between brands. Like they're all highly effective at blocking, or not blocking completely, but reducing UV radiation. But if whatever you like using, so if you like the sprays, use the sprays indoors. If you like the ones that like roll on like a deodorant stick, like use those. If you don't want to spend your life savings on sunscreen, buy the cheaper one that has a bigger bottle that you'll use more. Like I don't think there's one brand that I would sort of swear by as being superior to the others. And so whatever you're willing to use. I think what you do pay for higher, like more expensive sunscreens, you pay for the feel. Like it's not as white looking, or it goes on smoother. It doesn't leave your face as greasy. But those has nothing to do with effectiveness. So I don't know if that helps at all.
All right, next line.
For your EM and DM patients, do you recommend that we get screened for immunopathies such as CVID?
I would say no, we don't recommend that routinely. If somebody has CVID, maybe they should be looked for autoimmune diseases associated with it, but we don't normally look for it. Next one. Next.
I actually have a question for the room. I have always had extraordinary joint pain as one of my symptoms. How many of you have extraordinary joint pain as one of your symptoms? Okay. I would like to speak to you. I'm the guy in the Hawaiian shirt. I'll be outside when you break.
All right, that's next one.
My question is, where do you get the best antibody test study that tests all the antibodies? And when it goes, when you get to my rheumatologist, when you can do the test?
What was the second question? What information? Okay. So I would say the best one that I have seen so far is the Oklahoma University panel called OMRF, and they your doctor can send the labs there. That's one. And the other one that I have seen has done really good work is RDL Lab, which is out of California. They have pretty much all the antibodies available, including HMG coenzyme A antibody, MDF5 antibody. And I'm gonna, if you have any experience with that, no?
No, I know. I just second what you said. Yeah, I agree. If you do get it through the Mayo Clinic, I know they sometimes do subcontract with RDL, but if you're going to ask your rheumatologist to check a panel, the Myomarker 3 panel is the one usually we check because it has all of the antibodies in it. Because there's more than one myositis panel you can get from the Mayo Clinic, which is probably one of the easiest commercial labs to get it done.
And Myomarker 3 is RDL lab test. Myomarker 3. Okay. All right.
Currently, I'm on 1,500 milligrams of Cellcept, down to 3 milligrams of the prednisone. He's weaning me off like month by month. So I hope to be to the point where I'm off the prednisone, but I get the feeling from what I've heard this week that I'm probably going to need to stay on the Cellcept for another year at least.
So yes, in most patients, when I taper them off prednisone, I recommend them to stay on the second drug at the same dose for at least 6 to 12 months. And then if they have shown stabilization, means they've shown no disease activity after 6 to 12 months being off prednisone, then I would cut it down to 2,500 milligram, then 2,000 milligram, and slowly cut down their Cellcept. So I'm never in a rush to cut down their Cellcept.
Also, I'm taking itraconazole because of the interstitial lung disease and
Itraconazole?
histoplasmosis.
Oh, histoplasmosis.
No, it's probably a precautionary thing by the pulmonologist, but I'm just letting you know. So I guess I'm going to get the feeling I got to continue with that also as long as I'm on the Cellcept. That's the impression I've been getting.
Once you are on a 2,000 milligrams or less, your overall immune suppression is not that much. At 3 grams, your immune suppression is decent, especially if you're with prednisone. So yes, for now, but perhaps not when you're on a lower doses of Cellcept.
I'm on 1,500 right now.
Twice a day?
Just once.
Oh, you're just on once a day. Yeah, no, then that's not that much. Especially if you get off prednisone and drop it down to 1,000 milligrams, I think you can come off itraconazole if it's being given as a prophylaxis.
Okay.
I have a couple questions. First, on the antibodies, for somebody who's had a disease for a longer period of time, is there any benefit to having that antibody retested? Because say the last time I did it was 2008. Is there a benefit to having, what am I going to learn from having antibodies tested at this point in the disease?
Well, if you already had it tested, you said.
Well, in whatever was known in 2008, probably anti-gel.
My question to you would be, are you doing okay?
Yeah, I'm managing.
Yeah, then I don't see any reason to get that antibody. If the disease is well controlled, because that's all we want to achieve, right? And after 8 years, how many years you said? 10 years? 9 years of disease, all the probable clinical manifestation is already manifested itself. So it might be a useful information just for academic reasons, but I don't think it's gonna make or break your treatment or future care. I don't think so. I mean, 10 years of disease, yeah.
Dermatomyositis, is that pathology is always the same. So you can have, and you're basically looking at, say your skin's controlled and the muscle remains or whatever. Is it that your skin went into remission at some point on IVIG? Does that mean the pathology is always the same? It's not like you now have PM. It's a totally, right? Just because your skin, you have skin problem and now you only have muscle. What does that mean?
No, you always have dermatomyositis. Yeah.
Last question. So, say, my understanding, this is the technical side, the T cells and the B cells. Prednisone is more affecting targeting C, is that right? Rituximab is targeting B. Not all, but B. What if, how is one supposed to cope if you're sitting there saying you're targeting T and you're B? What do you have left now to fight?
Well,
I'm seriously, like, my B cells are zero.
Yeah,
and
yeah.
They don't return. So I'm always getting infected, always. So that's a huge thing.
So, well, first of all, B and T cells are not the only cells that your body has, right? There are many, many immune cells that protect your body, okay? B and T cells are a big part of it, but so when people are down on their B cells, when we give them rituximab, some patients have no infection, no problems, because the other cells are able to deal with it, so there's no problem. So what my answer to your question would be, depends on if you're having problems or not. If you're having problems or recurrent infection, then you have to reconsider, should I get rituximab or not, or should I move to an alternative treatment? But normally, if I give somebody rituximab, I don't worry that, oh, B cells are gone, then definitely this patient will have infection. That's not the case.
I kind of want to ask the whole room, this person with some advice. Has anyone had really good makeup that covers the redness, that doesn't irritate your skin?
She's asking for a good makeup that helps cover your skin.
Kat Von D makes a good cover.
I like this one from next time and I'll show you what I use from Bare Minerals. I really like this one.
What's the name of it?
It's called Bare Skin from Bare Minerals.
What company is making it?
Bare
I think we got it. All right, let's move on. Let's move on to this side. Oh, there's anyone left there?
I've been on Cellstat 1,500 milligrams and 20 milligrams of prednisone. And usually when I have a flare, they increase my prednisone. Would it be better to increase prednisone with my doctors trying to get me off, or increase into another immunosuppressive drug?
You know, I would change, because 20 milligrams is too much of steroids. So I would go to a different immune suppressive drug to be able to help taper your prednisone down. Okay. A different one, so that you're able to cut down your prednisone. So add another one or different one, so that then if that controls the disease, then you can come down on prednisone. All right, I'm going to go to this row. Oh, right there. Okay.
This isn't medication or anything. I've been in remission for the last 5 years, but my doctor, I've had a few cancer scares. My doctor seems to blame it on my myositis. Is there anything that is proven or disproven of this? And when I go to have my surgery next week to remove the possible cause of cancer, is there anything I need to tell my anesthesiologist before my surgery?
Yeah, okay. So I won't say DM causes cancer, but DM has a very well-known association with cancer. But if it's been 5 years of your diagnosis, the risk drops down after 5 years. And the fact that if you're in remission, surgery has no implication for you. The anesthesia or surgery has no implication. The only implication is if you have active muscle disease, then we have some recommendations. But if you're in remission, you're nothing to worry about. Okay, I'm going to move to this side. Any burning question? We only have a few more minutes. So, okay, people with burning question, raise hands.
Long story short question. I was recently forced due to insurance to change from a IVIG product to go to a different doctor, and are doing IVIG, but they're using a different manufacturing. They said it was the same, but I had not had a flare-up in 5 years, and I've had severe flare-up. I have been sicker than a dog. I mean, it's been crazy, and it's my skin and my muscles are
Yeah, finally you have more experience with IVIG.
At this point, I'm changing doctors, but I often, because I don't think she's knowledgeable enough, you know, to deal with my disease. Well, my question is, should I kind of look to go back to what I was on, or will my body adjust down to normal with the new product?
Yeah, it's a good question about brands of IVIG. I mean, people definitely respond differently to different brands, so it certainly does matter to people. It's not so much with effectiveness. I mean, they often are very similar in effectiveness, but reactions tend to be more of a problem. But yeah, I would definitely agree that try to go back to the old brand you've had success with before.
I have a question. What is the most common type of cancer you see associated to DM in females?
You know, breast cancer is definitely the most common, but there's a whole session on cancer-associated dermatomyositis in this afternoon, so I will welcome you there. But breast cancer is the most common. Short questions.
My questions were actually in relation to something that they've asked before. So I have UV clothing to go to the sun, stuff like that, and umbrella. Can I be in the sun if it's under? Because I have a 6-year-old, so I like to go to the beach sometimes to be with her. And I usually try like 4 o'clock, like you know, like the times are a little bit better. But can I go with the UV sun protection and the umbrella?
Yeah, you will get some reflection from the sand or the ocean, which still will be a little relevant. The other thing, I'm glad you're using the sun protective clothing because those are great. There's a supplement that some people take which does help, which I guess I could have mentioned earlier, called HelioCare, which I don't have any affiliation with, but HelioCare, you can buy from Walmart. It's a fern extract. It does actually help protect you from UV rays. It's used in UV sensitive disorders. You have to take like 2 pills. It only lasts about 2 hours, but it's very safe. And so I do recommend that to patients who want to do something additional to help. It's HELIO care, CARE, Helio.
My second question also in regards to the hair, I take biotin and all of that stuff, but you guys, as doctors, is there any oral medication, anything that could help with hair growth? Because
Yeah, it's a good question about what helps with hair growth. Hair loss is a hard problem, and we have like specialized clinics for hair loss in dermatology. I'm certainly trying to exclude you don't have another hair loss disorder, I guess, and then making sure that dermatomyositis is under good control. After you've excluded those 2 things and you just have thin hair, the main thing we recommend is people using minoxidil or Rogaine, 5% solution to help increase blood flow. Biotin and other supplements don't seem to really help hair grow, although they keep it strong. So no, it is a hard.
So do you think that Rogaine is fine? Because my rheumatologist said, oh no, it's not going to do anything to you because your hair loss is due to the dermatomyositis, so it's not going to.
Yeah, so that's right. So that's an important distinction. If you have active scalp disease or scarring, then certainly priority number 1 is to treat that. And that will help. Your hair should grow back once the disease is fully controlled, as long as there's no scarring. But as a supportive treatment, minoxidil does help sort of all, or Rogaine. Minoxidil is MINOXIDIL. It's the generic for Rogaine, 5% men and women.
Next one. Yeah, I got this one too. Yeah.
Okay.
Sorry. Go ahead.
Is there a good topical for scalp itching?
Yeah, scalp itching is tough. Mostly, actually, honestly, that systemic treatment is needed to control severe scalp itching. The topicals that we try, which are sort of partially effective, are clobetasol solution, which is a prescription, and fluocinolone oil, which is also a prescription. Those things do help, but honestly, if you've got really bad scalp itching, you probably would need to increase like the oral medicines you're taking.
In your experience, have either one of you guys seen any patients who have myositis and bilateral temporal hypertrophy with no history of TMJ or bite problems?
No. No, I've not seen that. No, it's.
Have you ever seen temporalis hypertrophy before? Like
No.
problems with no TMJ?
No, I don't recall. No.
Sorry.
Yeah.
I've had dermatomyositis for almost 15 years, and I have yet at this conference to hear anything about antibiotic protocol. And I know it's very controversial in Western medicine, but it's been very, very helpful for me. So I'm wondering, I guess, why it's not mentioned.
What antibiotic protocol you
It's
talk?
low-dose antibiotics over a long period of time to heal what they believe is a cellular infection which causes the myositis, which means they check for mycoplasma, and it's worked for me. I've recommended my doctor to one person at this conference, but I have yet to hear any doctor mention anything about it. And
No.
so I guess I want to mention it to other people that might have some success.
As per my knowledge, I have not seen any reports of low-dose antibiotics working for myositis. So, agreed. Yeah. Okay.
I have a, oh, sorry. When you say remission with DM, what does that mean?
That's a great question. So it means different things to different people, but what we generally mean when we say remission, there are two types of remission: remission on treatment and remission off treatment. Okay, and both are good things. So remission on treatment, when the physician says, that means they think your disease activity has gone to almost zero or near zero. You still have symptoms, which could be from the damage, previous damage, like skin damage, for example. You may have some scarring, some itching because of previous damage, or you may have some, muscle pain, a little bit of myalgia, muscle fatigue may still be there. But the disease activity, which in terms of biological parameters of active muscle weakness or inflammation of the muscles or CPK level or active skin disease, is gone to zero or near zero.
My question is piggybacking off of the one from earlier. My understanding, most DM patients don't have a lot of pain, but I have chronic pain. So do you find a lot of patients with chronic pain? And if not, does that kind of insinuate an overlap?
Yeah, I don't think that's right. I think many patients do have chronic pain. So, but I won't say all patients have pain. So there are patients who do have pain, and there are patients who have absolutely no pain. So they could be, we don't know if it's the pain, patients who have pain, do they have an overlap with fibromyalgia, that's why they're having pain, or not, or just the muscle disease or dermatomyositis itself is causing pain long term. I don't think we know that for sure, but there are patients who do have pain.
Okay, thank you.
Any comments?
My husband has DM, and he loves the sense of taste.
That's do you have any experience?
I can't say I've ever had that happen before. I mean, loss of taste can be from many causes. I wouldn't consider that from dermatomyositis. Yeah. Like there's medications can cause that, or neurologic conditions.
Yeah, medication
Yeah.
can. Methotrexate I've seen.
Oh, okay, yeah.
Yeah, I've seen with medication change in taste or loss of taste, but not from the disease. So if that's happening, you may want to switch your medication and see if that helps.
Thank you. I have a question about itching. So my husband has itching was one of his first symptoms with the horrible skin rash. Now he does not have active skin rash, but the itching persists and it's going to drive him crazy and he can't find any answers.
Yeah, itching is challenging. I mean, itching is its own sort of separate disorder in dermatology, which is evaluated. So it'd be good to make sure he's had all the causes of itching evaluated, not just from dermatomyositis. But dermatologists routinely do that, like work medical evaluations for itching. If he has a rash of any kind, I don't know if he has there's no rash.
No active rash, but he says that the itching has changed, that now it feels almost like he's being electrocuted.
Yeah, I mean that may. I mean we do know that in dermatomyositis some people do have sort of a neuropathy. They can develop a small fiber-like neuropathy from the damage. So I suppose that's a consideration, but I definitely think getting a neurologist on board to help see him if it's that kind of nerve-like pain could be helpful, and making sure he has a dermatologist to evaluate all the causes of itching.
So I have to leave, sorry, and I don't know if you probably have to leave as well. So we're gonna close this session.
My name is Chris Harris. I have dermatomyositis. I was first diagnosed in 2005. So this is my 12th year, and this is my first year to this meeting, which I'm kicking myself for, but going forward, I'll be at every one. My favorite part of this meeting is meeting the patients and their advocates, and I'm amazed at the support that I've received since I've been here from everybody. And I love that people have shared their stories, no matter how challenging, but I love the idea of hope for everybody. And my second favorite part of this meeting is the individuals who have donated their time to move this disease forward and try to find a cure, which includes everybody with the Myositis Foundation as well as the panel. Every person who has volunteered their time, the physicians, the physical therapists, the volunteers, and the fact that they've committed to do this as they move forward is amazing to me. And I love it, and I will be here again next year and the year after that. And it just gives me a lot of hope when I was very depressed. So thank you for inviting us, thank you for supporting it, and I look forward to seeing everybody next year.
Hello, my name is Anastasia Victorson, and I came here all the way from Stockholm, Sweden. I'm very happy to be here.
Is this your first time coming to myositis?
To this conference, yes. To the TMA conference the first time.
What's it been like?
It's been fantastic. Very informative. I've met my friends, my Facebook friends, and I hope I'll be able to come again. I have polymyositis, but I also have a syndrome that's called the anti-synthesis syndrome. I have antibodies, a lot of them, but anti-Jo1 is the most common one. And I also have ILD, quite serious. But getting medication, feeling quite okay. The doctor saved my life. Yeah, very good information. And it's also nice to see the persons. I read a lot. It's also nice to see them in real life, to be able to interact with the doctors. Yes, I'm just happy to be here, having met you too. Take care. And everybody else that hasn't been here, hasn't gotten a chance, please try, because this was really worth it. It's beyond my expectations, really. Thank you.